Hey everyone, welcome to Imaging Study. No more face chewing today. Today we are going to talk about the hepatic cystic lesions. In this lecture, we want to include several topics related to hepatic cystic lesions. There are other cystic lesions that we find in ultrasound practice when we are doing an ultrasound scan of the liver, like colorectal cyst, peribiliary cyst, or biliary cyst adenoma, which I want to discuss in our biliary system lecture. So don't forget to subscribe our YouTube channel and hit the bell icon beside the subscribe button to get updated about our future videos. So let's start with the hepatic cyst. These are benign congenital developmental lesions derived from the biliary endothelium. They might be simple or uncomplicated and complex or complicated cystic lesions. Think of a normal liver. Now we want to put a cystic lesion over this. The simple hepatic cysts are anechoic, round or oval in shape. Due to its fluid content, you'll get an acoustic enhancement posterior to this lesion. The simple cyst should have a thin wall with a regular margin. If it is a complicated cyst due to hemorrhage or infection, you may get some debris inside with or without fluid level. You may also get some septation, and there may or may not be the presence of marginal calcifications, casting or without casting posterior acoustic shadows if it is complicated. So make it summarized. So in case of uncomplicated simple hepatic cyst, the cystic lesion should be round or oval in shape with a regular sharp margin, thin or invisible wall, that is the wall thickness less than 1 mm. They should be anechoic with posterior acoustic enhancement due to accentuated sound transmission and posterior reflections. On color Doppler, there should not be any vascularity. If the cystic lesion is bigger in size, it may cause adjacent vascular compression or displacement also. There should not be or maybe few thin septations present. There should not be any mural nodule or wall calcification. In case of hemorrhagic or infected or complex or complicated hepatic cyst, you will get internal debris that might be clots or fibrin strands forming a layer or may be dispersed within the cyst. There may be presence of septation or the wall may be thickened. Marginal calcifications may also be seen. Now let's jump into some examples. Here you can see a tiny anechoic cystic structure on the right image. This is located within the right lobe of the liver. If you magnify the image and decrease the gain, you can see the outline is well visualized. This is oval in shape with a hyperechoic, very thin wall, but it is regular in outline. And at the posterior part, you can see a bright echogenic area indicating the posterior acoustic enhancement. So this is a simple hepatic cyst. Here are 3 pictures of a same lesion, and you can see a tiny well-defined round to oval anechoic cystic structure with posterior acoustic enhancement. On color Doppler, there is no vascular compression or displacement, as well as there is no internal vascularity. At the end of this lecture, we will talk about the hepatic arterial pseudoaneurysm, where you will see presence of flow inside the cystic lesion due to its vascular origin. Also, sometimes very hypoechoic solid mass may mimic cystic lesion, but at the time, with color Doppler, you will see some internal vascularity. Here you can see an anechoic cystic lesion within the hepatic parenchyma, and on color Doppler, there is no internal vascularity. You can see it is multiloculated. The margin is not quite regular. This type of slight lobulation may not be significant. We usually ignore them and count them as a simple hepatic cyst. Here is a large cystic lesion of more than 14 cm size, occupying almost the right lobe, displacing the adjacent vessels obviously. Let's see on real time. Here is the cystic lesion. It is huge. You can see some reverbation artifact inside and a huge posterior acoustic enhancement due to its fluid content. This type of large cystic lesion should have some degenerative change. So if you check carefully, you may see some debris inside, which may suggest the inflammatory change of this cystic lesion. So we need to focus a little more about the wall. We try to evaluate the margin carefully, and you can see some hyperechoic foci at the marginal part indicating the marginal calcifications. At this point, this cystic lesion is showing some wall calcifications. These are very thin calcifications due to huge enhancement. You can't see the post-acoustic shadowing well. On the right picture, you can see this area shows irregularity of the wall. These are due to the complication of the cystic lesion. Another cystic area, you can see a fine septation. On color Doppler, there is no internal vascularity, and this lesion is not displacing or compressing the adjacent vessels. Here is again another large cystic lesion. This patient had multiple hepatic cystic lesions, and you can see some septation inside. Another picture of this patient involving multiple segments. Let's jump into the real time. You can see the cystic lesions in segment 2 and 3. Here is the larger one involving the segment 8 with internal septation. In this type of cases, we love to search the spleen and kidneys to exclude cystic lesions in those organs. Here you can see the portal vein, and adjacent to it there is a cystic area. You may miss it as a bile duct dilatation. This one is the gallbladder. We put the color Doppler and you can see there is an anechoic cystic area with no internal vascularity, indicating it as a cystic lesion. Here on the left image, you can see a cystic lesion adjacent to the inferior border of the liver and no internal flow on color Doppler. On the right image, you can see a tiny bilobe anechoic cystic structure with a barely perceptible septation and posterior acoustic enhancement. Here, the transverse and longitudinal ultrasound scan of the liver showing an anechoic cystic structure. There is a very thin, almost invisible septation within it. There is a large anechoic cystic structure with posterior acoustic enhancement with a thin hyperechoic wall, you can see here. On the right image, you can see a small anechoic cystic structure adjacent to the liver capsule with a sharp outline. Now let's see some complicated cystic structures. Here is a longitudinal oblique ultrasound scan of the liver showing a large complex cystic structure with internal layering of the debris, possibly due to hemorrhage. This patient had gone through an MR scan showing layering low signal intensity in this complicated cystic lesion on axial T2 fat set image, reflecting the internal blood components. Here on the left image, you can see a large septate cystic structure with posterior acoustic enhancement. This patient came with an upper abdominal discomfort. On the right image, this patient presented with an acute right upper quadrant pain. You can see a thin-walled hepatic cystic lesion filled with uniform low-level internal echoes. You commonly see this appearance in adnexal endometrioma. So just like that, this cystic lesion is filled with the blood products. If you look at the left image, the first thing that comes in your mind is the Hydatid cyst. This cystic lesion shows thick septations which were not vascular on color Doppler. This picture is not available here obviously. These are diagnosed as organized thrombus within this cystic lesion. On the right image, this patient had gone through a CT also. The cyst appears virtually solid on ultrasound because of organized clot, but there is enhanced throat transmission. So you can see the distal part looks quite good enough. On CT, the cyst appeared more homogeneous, excluding the mass lesion. Here is the picture of a congenital hepatic cyst arising from the inferior left lobe of the liver. This cystic lesion had no internal flow on color Doppler. On the right image with high frequency linear transducer, you can see there is a thin rim outside with no internal septation or flow on color Doppler. The cyst was resected surgically and appeared to be a simple hepatic cyst. Here is a picture of the liver. You can see multiple cystic lesions within the parenchyma. Cystic lesions are also present in right kidney. This cystic lesion is the largest one with internal septation. You can see a huge posterior acoustic enhancement. Here's a picture of this cystic lesion. You can see huge size cystic area. Here's another cystic structure adjacent to the porta hepatis, and you can see the lobulated margin with posterior acoustic enhancement. The first thing come in my mind was the gallbladder. This patient had gone through a cholecystectomy, so the gallbladder is not visualized. In this type of cases, the thing that comes in our mind is the common bile duct dilatation, but the bile duct in this patient appeared normal, which is seen anterior to the portal vein here. Here's another cystic structure. You can see the irregularity of the margin, and on the right image you can see there is another cystic lesion in the left lobe of the liver. Another simple cyst with posteroacoustic enhancement. You can see the sharp margin and no internal flow on color Doppler. Here's the picture of this cystic lesion. You can see the posteroacoustic enhancement here, and on the right image you can see there is no flow with presence of normal adjacent vascular structures on color Doppler. Here's a picture of the cystic lesion occupying the left hepatic lobe in segment 2 and 3 with posteroacoustic enhancement. Another anechoic cystic structure. This is the gallbladder, and you can see an oval cystic structure here with posteroacoustic enhancement. Here's a patient with chronic liver disease, and you can see multiple cystic structures within it. You can see a huge ascites and pleural effusion in this patient. If you see a patient with a distorted liver with multiple hepatic cysts and presence of ascites with or without pleural effusion, if the patient is a female, then you definitely should scan thoroughly the adnexal region. You also should evaluate the pancreatic region. So these lesions may not only be the simple hepatic cysts, rather they may be the cystic metastases. We'll discuss about the cystic metastasis later. Here's the picture of these cystic lesions with chronic liver disease with ascites. Patient also had pleural effusion. Another patient with a bilobed cystic lesion with a fine internal septation. You can see these cystic lesions are scattered within multiple segments with no flow on color Doppler. Here is again these cystic lesions. Now to evaluate more with ultrasound, we have used 3-dimensional ultrasound in this patient. Let's see how it looks on 3D ultrasound. Here's the section of the liver in this patient, and you can see some vacuoles within the hepatic parenchyma indicating the cystic lesions. You may ask me why you are doing these things. Well, in near future, you obviously will see huge development of 3-dimensional ultrasound as our ultrasound manufacturers are focusing more on this topic. So expect some development of this modality to evaluate the solid and cystic lesions of the solid organs. So if you start practicing right now, then we'll enjoy when the newer technology develops. Here's a picture of a 48-year-old man showing a complicated cystic structure. The lesion is markedly hypoechoic involving the hepatic segment 7, mimicking the mass lesion, but on color Doppler there was no internal flow. To exclude the mass, this patient had gone through the contrast-enhanced ultrasound. Here you can see the contrast-enhanced ultrasound images, and in all vascular phases there is no contrast enhancement, indicating it as a hepatic cyst. Okay, so let's jump into the hepatic hydatid cyst. If you are from an endemic zone, then this may be a very important topic for you. Hydatid disease is the infection of humans caused by the larval stage of Echinococcus granulosus or Echinococcus multilocularis. Now what we'll get in hydatid cyst ultrasound? In microbiology or parasitology, you have read about the Hydatid disease. You have heard that Hydatid cyst has 3 layers. The inner hyperechoic layer is called the endocyst layer. There will be an around 1 mm thick outer hyperechoic ectocyst layer. Outside the ectocyst, due to the compression of the host tissue, you will get a hypoechoic pericyst layer. So ecto, endo, peri, 3 layers. If you get a cyst with 3 layers, first think of Hydatid cyst. Now how will it come? It may come as a cystic lesion with 3 layers. It may come as a cystic lesion with a thickened inner layer indicating the endocyst. Sometimes the endocyst layer may be separated, forming a septation. With this septation, you may find some echogenic debris which changes its position with patient's posture changing. These are called hydatid sand. If you get it, you will easily confirm it as a hydatid disease. Now when the patient comes with infective state, then we'll get multiple cystic structures within a cystic structure forming a honeycomb appearance. This is the infective state of hydatid cyst. If you cut it, you will get some ball-like cystic structures which look quite good as I have shown on previous image, but it is not good for the patient. Now if you give the patient a proper treatment, then the wall of hydatid will be calcified with or without posterior acoustic shadow. So hydatid may appear with all these features. There will be also water lily sign, which I'll show you next. But if you find hydatid confusing, then you can go for the antigen antibody tests which are available for hydatid disease. If it is not available in your center, then you can jump into the chest x-ray where you will get lesions within the chest. That is very common. If the chest is normal and you are not satisfied, you can go for a CT evaluation of the abdomen. Well, if you don't want to go for the CT due to pricing or radiation hazards, then you may easily go for the blood picture. There will be eosinophilia. If it's still confusing to you, then just ask the patient about dog and cats. Remember that if you don't eat dog feces or cat feces, hydatid won't touch you. Who the human eats dog feces or cat feces? We'll discuss it with example. Let's jump into the summary. Echinococcus granulosa's infection will come with an anechoic cyst with multiple layers, as I have mentioned already. You may get a honeycomb appearance, that is the infective state containing multiple daughter cysts, and there may be detachment of the endocyst layer from the pericyst forming a septation. There may be the undulating floating membranes within the cyst. In case of complete detachment of the membrane, you may see the water lily sign. There may be the snowstorm appearance when the anechoic cysts have internal debris, that is the hydatid sand within. If it can compress the adjacent bile ducts, then there will be bile duct dilatation. In case of Echinococcus multilocularis, you will get single or multiple echogenic lesions. There may be some irregular necrotic regions or microcalcifications, and it may appear also as ill-defined infiltrative solid mass lesions, and also they have a tendency to spread to the liver hilum. Invasion of inferior vena cava and diaphragm may also be seen. Don't forget to evaluate the lung, heart, and brain in suspected cases. If you give the patient a anti-hydatid therapy, then there will be reduction in size, the endocyst will be detached, and the echogenicity of the cyst will progressively increase. You may also see some mural calcifications. There are several systems for the classification of hydatid. The Lewell and McCorkle classification shows 4 groups, with a simple cyst containing no internal architecture except the sand, cyst with detached endocyst secondary to the rupture, cyst with the daughter cyst, and the calcified masses. There is another classification, that is the Garvey classification of ultrasound, where the hydatid is divided into 5 stages. On the first stage, you will get a homogeneously hypoechoic thin-walled cystic lesion. On stage 2, you will get the septations. On stage 3, there will be cystic lesions with daughter lesions. On stage 4, it will get slightly solidified, appearing as a pseudotumor lesion. And on stage 5, there will be calcification, indicating an inactive cyst. Now let's jump into the WHO classification, which is popularly used for classifying the hydatid disease. We'll show you each and every classes one by one. The CL is for the cystic lesion and CE for the cystic echinococcosis. Now first jump into the cystic lesion. It will be unilocular anechoic cystic lesion with no internal echoes or septation. Here is a unilocular simple cyst with a fairly uncommon morphology of hydatid. If you look at the wall, you can see there is a hypoechoic thin pericyst here. This may guide you to differentiate between a simple hepatic cyst and a hydatid one. Now the cystic echinococcosis stage 1, CE1 and CE2 will be the active stages. On CE1, you will get uniformly anechoic cyst with fine internal echoes, may only be visible after the patient's posture changing. There will be the presence of hydatid sand. Here you can see a well-defined unilocular hypotoanechoic cystic lesion with a few internal echoes. It is located in the segment 1 and 5. If you look at the wall, it is slightly thicker, and here is a hypoechoic fine area outside the wall may indicate the pericyst. So due to presence of this internal debris or sand, according to WHO classification, this cystic lesion is classified as CE stage 1. And in stage 2, you will get a honeycomb or rosette or multivesicular appearance containing internal septations and multiple daughter cysts. Here is a typical picture. You can see a large multiseptate cystic lesion in the segment 5 with multiple daughter cysts forming the honeycomb appearance, indicating it as a stage 2 cystic echinococcosis. According to the appearance of daughter cyst within the encompassing parent cyst, stage 3 is divided into 2 types, 3A and 3B. In 3A, you will get a daughter cyst having detached laminated membrane forming the water lily sign. Here is the cystic echinococcosis stage 3A. You can see a well-defined cystic lesion in the right lobe of the liver with low-level internal echoes. It shows a detached irregular laminated membrane inside it which appears to be floating within the contents of the cyst. This appearance is commonly known as the water lily sign, and according to WHO classification, it is classified as stage CE3A, which represents the transitional stage between the active and inactive disease. This appearance may come due to the decreased intracystic pressure or degeneration, host response, trauma, or maybe due to the anti-Hydatid therapy. Now on 3B, you will get the daughter cyst within a solid matrix. Here you can see a subcostal ultrasound scan showing a large oval-shaped cystic lesion with a few daughter cysts within the main parent cyst. You can see these areas are quite solidified, indicating it as a stage 3B cystic echinococcosis. Stage 4 is the inactive or degenerative cyst. There will be absence of daughter cyst. There will be mixed hypo and hyperechoic matrix forming a ball of wool sign. Here you can see a large heterogeneous cystic lesion in the liver showing mixed hypo and hyperechoic intracystic component, that is the ball of wool sign. This is the same patient that we have seen as honeycomb appearance of the stage 2, and now it represents an inactive stage CE4 hydatid cyst. So a serial scanning will help you staging quite well. Now come to the last stage, that is the CE5, that is also an inactive or degenerative stage where you will get an arch-like thick partially or completely calcified wall. Here you can see a solitary iso to hyperechoic lesion at the right lobe of the liver with a partial calcified wall and posteroacoustic shadowing. According to history and previous scan, this patient was diagnosed as stage 5 cystic echinococcosis. Okay, now forget about the stages and let's see some cases. Here's a transverse abdominal ultrasound showing an echinococcal cyst containing multiple peripheral daughter cysts and heterogeneous material at the central part with posteroacoustic enhancement. On the right image, you can see an oblique abdominal ultrasound scan showing a hydatid cyst with echogenic debris and detachment of the endocyst membrane, resulting in floating membranes within the pericyst, forming the water lily sign. Here's again the picture showing the water lily sign. Here's an ovoid hepatic hydatid cyst containing daughter cyst and echogenic internal debris. There is a partial curvilinear rim of calcification along the cystic wall, which causes mild posteroacoustic shadowing. So this is a stage 5 hydatid disease. On the right image, you can see another hydatid cyst with a stage 3B appearance. Here you can see a complex echogenic mass with enhanced transmission evidenced by the well visualization of the posterior part. There is a curvilinear echogenic scolex and highly echogenic debris forming the complex nature of the cystic lesion. On the right image, you can see the classic appearance of the honeycomb appearance of the hydatid cyst. Here is one of my cases. This patient had the history of eating cat feces. Well, I have already told you, nobody will eat cat feces. This patient came in a season of rice harvest. She gave me an history that during the rice harvest season, they deposit their rice in a space where she saw non-domestic cats to defecate. So that was the source of transmission of hydatid from cat to human in this case. So here you can see the honeycomb appearance cystic lesion. Let's see on real time, you can see this cystic lesion is having numerous cystic structures of variable size forming the honeycomb appearance. So don't eat cat feces. Here you can see a cystic lesion in the right lobe of the liver with a small mural nodule. 3 weeks later, this patient presented with right upper quadrant pain and eosinophilia. The detached endocyst is now floating within the cystic lesion. Here is again a hydatid cyst with internal daughter cysts. Here is a solidified mass with marginal calcifications indicating the inactive stage of hydatid disease. On the right image, there are finger-like projections within, which highly suggests hydatid disease. Here is a central liver mass with rim and internal punctate calcification. On the right, you can see the complex mass with multiple ring-like structures suggesting hydatid disease. During surgical resection, the cystic mass showed thick debris and innumerable scoleces. Here is a hydatid cyst in 62-year-old male with a large heterogeneous hypoechoic mass with multiple internal cystic areas in the right hepatic lobe. On contrast-enhanced ultrasound, the lesion was constantly avascular. Let's talk about the polycystic liver disease. Well, it might be autosomal dominant or recessive. The recessive one is present in children with a very poor prognosis if you don't do the liver transplantation. We commonly get the autosomal dominant one, which is usually present in adult patients. There will be multiple cystic lesions, usually more than 10 in number with 1 to 10 centimeter in size. They're anechoic with or without any internal debris if there is any infection or hemorrhage, as we have already told. You may get wall calcifications also. Usually there are no or a few thin septations with no mural nodularity. Due to innumerable cystic lesions, the liver parenchyma is usually distorted, and in severe cases, you'll get a little hepatic parenchyma with loss of liver segmental anatomy and normal shape. As it is an autosomal dominant disease, always try to look for the kidneys and spleen to exclude cystic lesions on those organs, which commonly coexist. Now in my practice, I feel confused with two differential diagnoses. There is a cystic metastasis and the biliary cyst adenoma or cystadenocarcinoma, which I will cover in biliary system lecture. In case of cystic metastasis, there will be mural nodularity and thick septation, and the wall will show vascularity. In case of biliary cyst adenoma or cystadenocarcinoma, there may or may not be presence of mural nodule depending on the malignant or benign nature. Usually these are multiseptate cystic mass with the septations having vascular flow on color Doppler. These are common in women with associated dilated biliary tree. Here's the picture of the liver showing innumerable cystic lesions throughout the liver parenchyma in a patient with polycystic liver disease. On the right image, you can see no internal flow on color Doppler. Here's another picture with an autosomal dominant polycystic liver and kidney disease showing multiple cystic structures of variable shape and size within the liver parenchyma, and the kidney is also enlarged with multiple cystic lesions within, which is a common association. Here's one of my cases, and you can see multiple cystic structures distributed throughout the liver parenchyma. This is the right kidney showing a diffuse cystic change with an enlargement of size. So this patient was a case of autosomal dominant polycystic disease. Another case with multiple anechoic cystic lesions within the liver parenchyma. You can see the kidneys are enlarged with multiple cystic structures within. Now let's jump into a rare case, that is the ciliated hepatic foregut cyst. Well, this is a foregut developmental malformation in liver with non-specific radiological features. Usually they're benign but may get malignant regeneration, which is commonly the squamous cell carcinoma. On ultrasound, you'll get a single subcapsular unilocular cystic lesion located within or close to the medial segment of the left lobe, that is the segment 4. It may contain internal echogenic foci, and obviously there will be the posterior acoustic enhancement. Here's a case of ciliated hepatic foregut cyst showing a well-defined ovoid subcapsular cystic lesion in segment 4 with a posterior acoustic enhancement. On color Doppler, there was no internal detectable flow. Here's another patient with a ciliated hepatic foregut cyst at segment 4, which is subcapsular in location with numerous internal echogenic foci consistent with mucinous debris. On the right image, you can see the color Doppler shows no detectable flow within the lesion. Here's one of my case. You can see the cystic lesion at the subcapsular region. Magnifying the image, you can see it is subcapsular in location with thin wall with anechoic homogeneous ecotexture and posterior acoustic enhancement. Here's the picture of this lesion. The subcapsular appearance of a cystic lesion in a young patient is usually the common feature. Now let's talk about the Caroli disease. Though it is a topic of biliary system lecture, we just want to focus it a little bit. This is divided into two variants, Caroli disease and the Caroli syndrome. The Caroli disease, that is the pure form, is the congenital multifocal saccular dilatation of the large intrahepatic biliary ducts in absence of other hepatic abnormalities. These are usually diffuse in nature, but occasionally may be local. The Caroli syndrome is the complex form, which is a more common variant characterized by cystic dilatation of large intrahepatic ducts with hepatic fibrosis and portal hypertension. This is almost always diffuse in nature. So when you get Caroli disease with the feature of hepatic fibrosis or portal hypertension, then you may term it as a Caroli syndrome. Now what will you get on ultrasound? There will be dilated intrahepatic biliary tree, which may be focal or diffuse, saccular or fusiform, with internal slush due to biliary stasis, or may also contain calculi. Now there are two common signs that we describe in Caroli disease. The first one is the intraductal bridging sign, where you'll see the echogenic septa partially or completely traversing the dilated lumen of the bile ducts. The second one is the central dot sign, which may also be present in color Doppler. There will be a small portal venous branches partially or completely surrounded by the dilated intrahepatic biliary tree. So if you put the color Doppler, you will see a color flow in the portal radicals surrounded by the dilated avascular intrahepatic biliary tree. As a complication by cholangitis, there may be the formation of abscess also. Here's the picture. You can see a young patient with Caroli disease shows multiple dilated intrahepatic ducts. You can see echogenic portal radicals are surrounded by dilated ducts forming the central dot sign. Here is the color Doppler image forming the central dot sign. In same patient, you can see the portal radicals showing color flow surrounded by the dilated intrahepatic ducts. Another patient with Caroli disease showing multiple dilated intrahepatic ducts. This is the echogenic septum traversing the dilated bile duct lumen, dividing into two parts. This is a common finding that we get in Caroli disease. Here is the central dot sign. You can see multiple dilated intrahepatic biliary tree with a central portal venous flow. This is a young boy came with a history of diagnosis of Caroli disease and hepatic fibrosis, that means the Caroli syndrome, during early ages. On ultrasound now you can see multiple cystic areas within the liver, which are cystic dilatation of the biliary tree, not the hepatic cysts. Another color Doppler ultrasound in a patient with Caroli disease showing the saccular dilatation of the branches of left hepatic duct. This is the medial segment branch of the left duct. This is the long section of the branch of portal vein, which is surrounded by the anechoic bile duct. Here you can see the intraductal bridging sign. Here is again another patient with a Caroli disease, and you can see the dilated intrahepatic duct adjacent to the portal vein. On the right image of the same patient, you can see the central flow with surrounding dilated intrahepatic ducts. Now let's talk about the cystic or necrotic metastases. They may or may not demonstrate posteracoustic enhancement. Well, there will be mural nodules, thick walls, fluid levels, internal septation or debris, which will help differentiate between the simple and metastatic cystic lesions. The necrotic center may be lined with irregular walls and may contain debris. The primary sources are usually the cystic malignancies like cystadenocarcinoma of the pancreas, ovary, or mucinous carcinoma of the colon. The necrosis or treated metastases are from sarcoma, squamous cell carcinoma, or large colorectal metastases. Also, they may get metastases from the neuroendocrine and carcinoid tumors. Let's see some cases. Here you can see a cystic mass within the liver parenchyma. This was a case of metastatic liposarcoma from the thigh. Here is a cystic lesion with internal echoes. This was a metastatic sarcoma from the small bowel with necrosis. Another one, a highly echogenic metastasis with a well-defined cystic component that is highly suggestive of metastatic carcinoid or neuroendocrine tumor. Now let's come to the last component of this lecture, the hepatic artery pseudoaneurysm. This can be caused by blunt and penetrating trauma or percutaneous intervention procedures, including the liver biopsy, right upper quadrant surgery, and pancreatitis also. It's a well-known complication of the liver transplantation cases. On ultrasound, you will get anechoic lesions with a variable amount of mural thrombus. They may mimic simple cyst also, so always try to put color Doppler ultrasound when you get a cystic lesion within the liver. Usually we see the to and fro flow within the pseudoaneurysm, which may not be well visualized in hepatic artery pseudoaneurysm because in this case the neck is quite difficult to visualize. But on color Doppler you will get swirling of flow, which may be helpful for confirmation. Here is a cystic hepatic lesion. I would make it a hepatic cyst, but if you look carefully, you can see there is a communication between the cyst lumen and the adjacent blood vessel. That will instruct you to use the color Doppler ultrasound. Here, the color Doppler image on the right, you can see there is an internal flow within the lesion, and on pulsar Doppler, you can see there is an arterial flow in the vessel supplying the lesion. So it indicates it as a case of hepatic arterial pseudoaneurysm. Here is a transverse color Doppler image of the mid part of the liver, showing a round cystic lesion with internal debris. On color Doppler, you can see the flow around the debris. A turbulent arterial spectral Doppler waveform was identified at the neck region. The angiography confirmed that this was a partially thrombosed intrahepatic hepatic artery aneurysm. On the right image, you can see a 63-year-old man with hepatic artery pseudoaneurysm detected on color Doppler at the 7th postoperative day with a periportal round structure and turbulent flow. Here is a color Doppler image showing the typical yin-yang pattern or Pepsi sign within the pseudoaneurysm originating from the hepatic artery that is shown here with aliasing. You can see a phloboid area here suggesting partial thrombosis. Thank you for watching this video. Hope it helps. If it helps, don't forget to subscribe this YouTube channel and obviously share this video with your friends. That will help our channel grow a little more faster. See you on the next one. Have a nice day.